Welcome to EuroPCR 2026. I'm Evald Christiansen from Aarhus University Hospital in Denmark, and I'm here with Margaret McEntegart from New York, who presented the result of the FRACTURE IDE Trial today. Margaret, can you share the results with us?
Sure, thanks Evald, and it's lovely to be here with you. So we did the FRACTURE IDE trial to investigate the performance of this novel optic and laser-based IVL system, SEISMIQ. And we wanted to see how it would perform in patients with severe calcified lesions. So the trial was conducted in Europe and the USA. We recruited 420 patients, as I said, with severe calcium, defined either in angiography or with IVUS or intravascular ultrasound or OCT. And the patients were all treated with the device, and then we followed them up for a primary endpoint of safety, freedom from 30-day MACE, and effectiveness, procedural success. We had a clinical events committee, core lab, and I got to present the results of that today. Interesting things about the trial were that we certainly confirmed that the calcium was severe, both on the core lab angiographic and the OCT sub-analysis, with the mean arcs being over 270 and the calcium being thick, about 0.9 millimeters. And also we had a high prevalence of nodules, about 27% of nodules. In terms of the actual outcome of the trial, the primary endpoint of safety was achieved in over 93% of patients. So there was about 7% MACE rate, most of which was driven by protocol-derived diagnosis of procedural MI, and we can discuss that a little bit more. I know you're very interested in that. And in terms of the effectiveness, we again, over 93% procedural success. And again, that almost 7% was driven by these procedural MIs counting as MACE events.
So the trial reached its target also with the confidence interval of what you achieved. So are you concerned about these procedural myocardial infarction? Do you think that will translate into something that will influence the prognosis? Or why was this CKMB marker release added as an endpoint in this trial?
Yeah, it's an interesting question. And just to go back to the statistics, so we had pre-specified performance goals for safety and for effectiveness at 86%, and that was based on the DISRUPT and the ORBIT-2 trials, DISRUPT-3 and ORBIT-2. And as you said, the lower bound of the confidence interval for both was achieved, so we achieved non-inferiority against the data from those two trials. And as you said, the safety of the device was really strong. So procedurally, we only had one type D dissection, no perforations, no slow reflow, and then just these procedural MIs. So quite interestingly, we did a sensitivity analysis looking at the SKY and universal definition to compare it to this protocol definition of MI that was just 3 times CKMB. And actually the rates were then about 0.4%. So they dropped dramatically from the 6.8 to 0.4%. So I think that these are enzyme release events as opposed to clinical events. And, I don't think in the context of what we know about the SKY definition and the universal definition that they will translate into meaningful adverse events or impacts on the patient. What's your thoughts on that?
Yeah, I completely agree. If we look into the proportion having a force universal or SKY defined, it was less than 1%.
Yeah.
So procedural myocardial infarction in that level is very low, and I see it not as a device-related marker release. It's typically side branches that are shutting down, and the calcified disease is often sitting in branch points. So I'm not concerned about that. I'm more concerned about big myocardial infarction that fulfills the SKY criteria or the force universal. So for me, when I see this data, this is a very safe device. It seems to give a very predictable procedure. There were no residual stenosis in the lesions. We were able to put a stent in all the lesions. So for me, I think we are having a chance to get a device that has a very predictable result. We can get what we want, and the emitters that are sitting in 4 quadrants in the device makes it more likely that you will target the nodular calcium.
Yeah.
So I think we will have more predictable procedure with this device. But of course now we are waiting for the approval, and we will see how we can generate clinical experience.
Yeah.
So I think we should follow that at least in registries to see how is the performance.
Yeah.
Another thing I saw is that a lot of the cases were done imaging guided. So if we get the approval and we want to teach operators to use this, should we say you have to use imaging? For me, I think we can only say that we can achieve this result if we do it imaging guided, because this trial was an imaging guided trial, wasn't it?
Yeah, 88% of patients had imaging. And I think we're seeing that come through in all the sub-analysis from all the other calcium trials as well. That actually, if you split the population in those trials by imaging guided versus non-imaging guided, consistently the patients do better if they get imaging guided PCI. So I think the message is really strong now that in calcific coronary disease, we really have to be doing imaging guided PCI.
And also about the dose response. When is enough? How many cracks are you going for? Are you doing a compliance test with the balloon? Are you doing it imaging guided? Where do you deliver your energy? How would you interpret that?
I think that it's a really interesting point, because as we get devices like SEISMIQ that have so much energy to deliver 320 pulses, the quad emitters, in the study actually the mean pulses delivered was 222 of 320. So obviously the operators were aware of the fact maybe they didn't need to use all the therapy. I mean, this is potentially a fantastic scenario for clinicians, because you have all these pulses to treat long segments of calciums and maybe multiple vessels. Where the titration is, I don't think we know yet. How many fractures do we need? How much luminal gain? How much new penetration of imaging signals through the calcium do we need to know that this is a threshold at which is optimal time for you to go on and implant your stent? I think we still need to do further digging into that.
I completely agree. And maybe also when we search for the landing zone for our stent, the spot where there's most calcified part is not where you're getting the minimal stent area. So maybe we miss some calcified regions outside the most severely calcified part. And that's also where imaging helps us. That we should also deliver some energy outside, depending on where our landing zones are, because we're not just treating the region where the most calcified part is, we are treating the lesion that should be stented. And I think that imaging can help us to distribute the energy in the vessel where we want to get good stent expansion overall. I
think that's right, and I think we have learned that we get very focused on where we see the most severe calcium, but as you say, usually the MSA is either towards the distal end of the stent or actually an area of more eccentric calcium that we've kind of not paid attention to. So I think you're right. I think imaging really draws our eye into making sure we treat the extent of the calcified segment completely.
Great. I think it was very interesting. Margaret, thank you for sharing these details about the FRACTURE IDE trial. I learned a lot, and I really look forward to read the paper and get the approval for this device, because I think it is a way forward to treat more patients with more severe lesions. This is what we are here for. Thank you very much.